going to be talking about clinical documentation improvement for acute renal failure for the emergency department. We need to talk about the downgrades for acute renal failure are common. The lack of standardization of documentation is a cause of this. It reduces the severity of illness for the patient. It causes queries to be generated from the CDIR coding department. Lost revenue for the hospital and for the services provided. Appeals process takes time and there's loss of revenues. So what do the payers do? This is a classic denial letter. So this was a 56-year-old male who presented with pain, swelling, and drainage of his right foot. Medical history was positive for hepatitis C, hypertension, reflux disease, and various other issues. The patient also had chronic kidney disease. The patient was treated with antibiotics. Initial creatinine levels were between 1.85 and then went down to 1.72. The denial rationale was that there was not a threefold increase in his creatinine levels, did not have a GFR decrease greater than 75%, and did not have anuria for 12 hours, and did not have creatinine levels greater than 4.0. There is no document to support the diagnosis of acute renal failure. So by the time you have anuria for 12 hours and your creatinine is greater than 4, you probably are in acute renal failure or probably are on dialysis, right? So what should we do? We should use standardized definitions of acute renal failure. Try not to use abbreviations as acute kidney injury, because acute AKI could mean acute kidney injury or acute kidney insufficiency. Do not use terms as acute renal or kidney insufficiency. Use the KDIGO guidelines for acute renal failure. So acute renal failure or acute kidney injury are defined by an increase in the serum creatinine greater than 0.3 milligrams per deciliter within 48 hours, or an increase in the serum creatinine 1.5 times baseline, and a urine output less than 0.5 ml per kilo per hour for 6 hours. Probably not relevant to the ED physician because you're not probably watching the patient for 6 hours and monitoring his urine output for 6 hours. So the important takeaways are to document the creatinine. Try to establish the baseline creatinine. One look at the previous creatinine from the previous visits is important, and you should document the baseline. And use standardized criteria using the KDIGO criteria. So as an example, there's an increase in the serum creatinine greater than 0.3 milligrams per deciliter. The range, most of the places, is 0.6 to 1.2 milligrams per deciliter in an adult male. Establish the baseline creatinine if possible. Document insertion of a Foley catheter, administration of IV fluids, and other interventions that may have decreased the creatinine. Acute kidney injury criteria are the same even if the patient has chronic. So various scenarios for the ED physician: if there's no baseline creatinine available, which generates confusion most of the times. So if the baseline creatinine is not available and the creatinine was elevated at 1.8, this is greater than 0.3 milligrams per deciliter for the normal range for acute kidney injury or failure. It is okay to document symptoms and say that this is suspected acute kidney injury or acute renal failure or concern for acute renal failure. If the baseline creatinine is available, as an example, the creatinine was 1.16 months ago and now the creatinine is 1.6, the patient meets the KDIGO criteria. If the baseline is available and the creatinine is 1.8, the patient has chronic kidney disease and now the creatinine is 2.4, this meets the KDIGO criteria as well. You can document acute on chronic renal failure. So remember, dehydration, and not all patients with dehydration have an increase in the creatinine. The kidneys, you all know, autoregulate. If the creatinine is increased and meets acute renal failure criteria and you gave intravenous fluids, document it. That meets the acute renal failure criteria. So the bottom line of all of this is the document accurately, save queries, impact the DRGs. No, you don't have to remember the staging criteria. Just calling it acute kidney injury or acute renal failure is sufficient. You don't have to go into the staging of it. Try to establish the baseline and try to establish the cause, pre-renal, renal, or post-renal. Not necessary, but try to think about what exactly the cause of renal failure could be in your patient. That is the end of the presentation. I thank you for your